I'm a consultant general in colorectal surgery in Mukhtar Sheikh Hospital. What I will be discussing today is the evolution of rectal cancer treatment, rationale behind organ preservation, and by organ preservation we mean the rectum. Do we need to preserve rectum, or for any cancer or pathology we need to remove it altogether? How TAMIS started and has evolved over the years, patient selection, the role of TAMIS or transanal endoscopic microsurgery in early cancers, preoperative workup for these procedures, what should be the follow-up, and then I'll discuss my own personal case here from Pakistan. I have no disclosures. This is just a brief history. You can see over the years how rectal cancer surgery has evolved. From 1826, when Franck performed the first rectal surgery, up till current age, there has been gradual progress. People have been making contributions, and we have been seeing new and new avenues in treating this disease. We also note that over the years, gradually, there has been improvement in patient outcomes. Patients' mortality, local recurrence has reduced. The mortality now for any rectal cancer surgery has reduced to around 3 to 4%. The local recurrence rate is around 5 or maybe less. However, this was noted that the comorbidities and the stomas, this is still high as compared to other outcomes for rectal cancer surgery. So there was a need that with increasing numbers of early tumors, efficacy in modern neoadjuvant therapies, technology availability, increased number of morbidities, elderly population, and patient choice. These were the factors which were driving this thing that should we change our management for rectal cancer, especially the early rectal cancers. So this is what an early rectal cancer may look like. Do you think this taking out the whole specimen with the piece of fat is a good treatment for that, or is it too much? And then if you think about this, that for this particular small lesion, we have taken this whole lump out, we have caused this problem for the patient, which will take a long time to heal. We have caused urinary dysfunction, sexual dysfunction, and then for these group of people, are elderly, do they really need this procedure? Do they need an extensive resection for such small lesions? So these were the factors which were driving the main reason why people were thinking, should we be doing something else in this group of patients or for these reasons? The other thing is, we all are familiar as a colorectal surgeons, and for the audience and students, when we perform colorectal surgery for rectal cancers, one of the major complications that these patients feel is low anterior section syndrome. It's a mixture of things that these people face throughout their life, and the incidence is as high as 45%. So this is also one of the reasons that we need to think that, do we need to change our practice or not? I'm not advocating for this procedure. I'm just trying to build a case here. And then you have to think about this when patients start writing these books. This is a book written by a patient in UK. And then this gets you thinking that the patients are thinking from a different frame of mind. For them, preserving their organs, preserving their body is important. It's not just about getting rid of the cancer and leaving them with comorbidities. So in 1985, this is a German surgeon, Boos. He basically introduced this concept, although transanally cancers were being removed before, but he introduced this concept that we can remove early rectal cancers, benign rectal diseases, and other rectal problems. We can deal with them by minimal invasive surgery, by using this special instrument that you can see him holding in his hands. This is called the system you use for transanal endoscopic microsurgery. This is the instrument, and you can see it looks quite complex, but basically this system you can fix with the patient table, and then you can operate while using instruments. The advantages of this new minimal invasive intervention was that the surgeons get a better visualization. There was a stable platform. It's not moving too much, so you get stability while operating in a small window. More proximal cancers, like higher up to 20 centimeters up in the, in fact that would be up in the sigmoid colon, you can operate even on those. less fragmentation of the specimen. When people were removing these cancers from the anal canal through the transanal approach, there was fragmentation of the sample. The cancer was broken down into pieces. So this led to less fragmentation, improved oncological outcomes, and low morbidity and mortality. The disadvantage is, however, it's an expensive instrument. Not every setup can afford this. It has a very high learning curve, and this is very important, the high learning curve, and I'll make a point about this later. The risk of defective anorectal function, you can see the size of the proctoscope is humongous, so obviously it left with some disability, although it was short term. And then the complication rates were 5 to 15%, minor and major around 3%. So TAMIS was introduced. Now, transanal minimal invasive surgery is basically a modification of transanal endoscopic microsurgery. For the medical students here, this might not make much sense, but basically, there's a cancer in the rectum. We want to remove that cancer. So what options we have? One option is we remove the whole part of the gut like we do old-fashioned way. We open up the abdomen or use a laparoscope and take out the cancer. The second option is that we go through the anal canal and we shave it off the bowel. So this is what we're talking about, that these are the new inventions or new interventions, not new, relatively new, that we are using to basically remove these cancers from the gut. So TAMIS was introduced. And the benefit of TAMIS was that basically in this, that expensive setup or instrument sets, we can avoid that. We can use normal laparoscopic instruments. But as I said before, the effectiveness of an operation is how many can perform it with good clinical outcome. As I said, TEMS, which is transanal endoscopic microsurgery, has a very steep learning curve. So not everybody can perform this easily. I remember my first case back in fellowship, and it was just cursing throughout the case because the setup is not easy to grasp. So if it is very difficult, then effective in some hands, but limited effectiveness in many. So technology is the one which should reduce the difficulty in execution, which automatically will increase the effectiveness and indirectly benefit patient. So this was driving factor behind this. So in 2010, this paper was presented by a team, and basically they introduced this concept of transanal minimal invasive surgery. Advantages of transanal surgery: use of single access multi-channel port. You need single access. Familiar laparoscopic instruments are used. Can resect proximal, mid-rectal, benign early stage cancers. Technically feasible and requires minimal setup. It's cost effective. You don't need to buy all the stuff because you already have it for laparoscope. There's no need for repositioning. The patients can be in their lithotomy position, they can be in prone jackknife position, and can achieve high quality excision with superior or to traditional transanal excision, but comparative to endoscopic excision. What are the indications? In which patients are we using transanal endoscopic microsurgery or transanal minimal invasive surgery? Rectal polyps, most of the adenomas are removed this way. Pelvic abscess are being drained this way. Rectal stenosis or dilatation of anastomotic strictures are being treated this way. Treatment of anastomotic dehiscence, it has been reported in literature. Repair of lectovaginal fistulas, anal prolapse, solitary rectal ulcers, and rectal endometriosis. So you can see there is a whole list of things which have now surgeons have performed throughout the world using this intervention. Can we do malignant cases with this as well? So yes, there was initial evidence that low-grade neuroendocrine tumors, stage 1 adenocarcinomas with favorable histology, and I will come to this, what is favorable histology, and then the TAMIS technique can also be used for more advanced lesions in patients which are not fit for radical surgery, like the old man I just showed you earlier. So key factors in decision making for operating on malignant lesions: is the cancer or the lesion is there any lymph node spread? Can primary tumor be excised with negative margins? And is there any visceral metastasis? Don't perform these surgeries, and this is the take-home message for young surgeons. Do not perform these operations if you do not have an excellent radiology and pathology support. These cancers need a very dedicated input from radiologists because you have to stage them, and if you don't stage them properly, then you're not doing the right operation. And second is a pathology service. Your pathologist is going to, it's going to give him hell of a time or her hell of a time to go through these specimens and then find out where the tumor is invading. It's going to the muscularis, it's going to the submucosa, so it becomes very difficult and challenging. So if you have that thing available, that service, only then I would suggest that you should start doing these procedures. And the second most important fact is you should have a colorectal MDT. You should not be making these decisions on your own. These are complex decisions. These patients have to be taken on board, and these patients should be given all the information, and then it should be brought forward in front of an MDT. So resection is for most part not limited by feasibility, but the optimization of the outcome. So one factor when we decide malignancy, that I'm going to operate on this particular lesion and I'm going to take it out with transanal minimal invasive surgery. So what are the things that I need to look at while sitting at the MDT? The first one is depth of the tumor. And there has been lots of work on this, that what does this mean? How deep a cancer has to be within the wall of the bowel to be deemed fit for this procedure? And if it is beyond that, then we should not be doing this procedure. So T1 tumors are the most suitable tumors for this kind of procedure. They have a low lymph node metastatic potential. Whereas T2 tumors, at the moment with the current evidence available, I would not say we should be going for those unless there is a contraindication for radical resection. Then Japanese have done a lot of work into these polyps and tumors, and they have basically given us this beautiful classification. We use Haggett's classification, there is Kikuchi classification, Kudo's classification. They're all different ways of labeling how much a tumor has grown within the polyp or within the wall. So Haggett classification is used for studying polypoid lesions. And as you can see from the picture, basically the tumor has basically grown within the polyp, and you can see the more it extends into the polyp, that is the level that you label it as Haggett's level. And for Haggett level 1, 2, and 3, we can perform this procedure. Whereas for Haggett level 4, we consider this close to T2 or as a high-risk cancer. The next thing is lymph node metastasis based on depth. So this study was done in Japan as well, and they found out that we can classify, this was done by Kikuchi, a very famous pathologist, and what he did was basically he stratified these polyps in sessile lesions, which are not raised above. Polyps are which are protruding out, and sessile lesions are flat lesions. So in flat lesions, basically the depth of the tumor or the lesion can be subclassified into 3 categories. SM1, which is penetrating up to 500 micrometers. Now these depths have been reported differently in different literature. I've just chosen this one. SM2 is roughly 5 to 1000, 500 to 1000, and SM3 is more than 100,000 micrometers invasive into submucosa. So nodal involvement, what does this mean? When we are operating on cancers, what is the main purpose of treating a cancer? I'm just going to change my tone for the students. I see everybody sleeping right now. So I'm going to change to, I'm just going to skip and I'm going to come to Urdu. Okay? आप लोगों के लिए सिर्फ ये चीज़ एज ए स्टूडेंट, जब हम कैंसर की सर्जरी करते हैं तो हमारा एम क्या है? पहला एम है, क्या एम है? पहला क्योर, ठीक है, क्योर पहला एम है. जब क्योर अचीव नहीं होगा तो फिर हम किस पे चले जाएंगे? पैलिएशन के ऊपर, ठीक है. क्योर करने के लिए हमें डिजीज की 2 एस्पेक्ट्स देखने हैं. एक, वो लोकली कितनी फैली हुई है, उसकी कितनी एडवांस है, और दूसरा वो जिस्म में कितना फैल चुकी है. तो जब हम कोई भी पेशेंट की ट्रीटमेंट प्लान करते हैं, फॉर मेडिकल स्टूडेंट्स पर्सपेक्टिव, just putting it simple as in a simple way, that we basically consider these two factors: locally how advanced the disease is, और सिस्टेमिकली ये कितना फैल चुकी है. अब सिस्टेमिकली वो लिम्फ नोड्स में भी फैलेगी, वो ब्लड में भी जाएगी, और वो वहां से आगे डिफरेंट ऑर्गन्स में जाएगी. सो सबसे पहले हमने कोशिश करनी, हम देखें कि लोकली किस तरह फैली है. तो टेम्स के अंदर या टैमिस के अंदर हम ये देख रहे हैं इसके अंदर कि ये जो ट्यूमर बना है बाउल की वॉल के अंदर, ये लोकली कितना फैल रहा है. जितना सुपरफिशियल होगा वो सर्जरी सुपरफिशियली उसको शेव करना आसान है. टैमिस में हम यही करते हैं, ट्यूमर को शेव कर देते हैं ऊपर से, अगरचे वो फुल डेप्थ लेते हैं उसकी. दूसरा, अगर वो ज्यादा नीचे चला गया है तो उसको हम शेव नहीं करते, हमें गट का वो पीस पूरे का पूरा विद इट्स लिम्फेटिक ड्रेनेज निकालना है. अब इसकी क्या वजह है, क्यों ये हम कर रहे हैं? ये इसलिए कर रहे हैं, जो एक्चुअल जो इसके बीच में बेसिस है वो ये है लिम्फ नोड्स. जो जो ट्यूमर साइज में बढ़ता है, ये हमें रिसर्च ने बताया, बेतहाशा रिसर्च हो चुकी है, जो जो ट्यूमर साइज में बढ़ेगा, डेप्थ में बढ़ेगा, ये फैलेगा बाहर की तरफ इन अदर ऑर्गन्स, लिम्फेटिक्स के थ्रू मोस्ट लाइकली, या लिम्फोवैस्कुलर इन्वेजन, लिम्फ वैस्कुलर इन्वेजन के थ्रू। तो जो जो साइज बढ़ता जा रहा है ये माइक्रोमीटर्स में, हम देखेंगे कि लिम्फ नोड इन्वॉल्वमेंट बढ़ती जा रही है, यहां तक कि SM3 में इट गोज अप टू 25%। तो अगर मैं SM3 पेशेंट को आपके पास भेजता हूं और आप उसकी ऑपरेट करते हैं, और मैं आप कहते हैं कि ठीक है मैं इसकी शेव कर दूंगा, इसको मैं कैंसर से बचा लूंगा, दिस इज इनएडिक्वेट, क्योंकि मोस्ट लाइकली 1/4 चांस है आपने उसके अंदर लिम्फ नोड्स छोड़ दिए कैंसर वाले, और अब वो वहां से ट्यूमर स्प्रेड करना शुरू हो जाएगा। सो दिस इज द टेक होम मैसेज फॉर स्टूडेंट्स कि कैंसर की ट्रीटमेंट में सिस्टेमिक डिजीज को हम कैसे देखते हैं, उसको हम कैसे मेजर करते हैं, और फिर उसके बाद प्लानिंग कैसे करते हैं। सो फॉर टैमिस एंड फॉर टेम्स, SM1 and 2 is okay, even 2 is questionable, but SM1 is definitely, हम SM1 ट्यूमर्स उनको शेव करके निकाल देते हैं और उसको फॉलो अप पे पेशेंट को रख सकते हैं। SM2 डिबेटेबल है, इसके साथ और भी बहुत सारे पैथोलॉजिकल फैक्टर्स देखने हैं। SM3 नो, ट्रीटेड एज फुल एक्सीजन। ये वो साइंटिस्ट हैं जिन्होंने इसके ऊपर सारा डेटा कलेक्ट किया हुआ है। ये नीचे से बाहर खत्म हो जाएगा किसी को। ये जो डेप्थ ऑफ इन्वेजन है, जी आप कंकरेंटली डोजल सेक्शन में कर रहे हैं, जो प्री ऑपरेटिव जो आपने दिया बायोप्सी, ये प्री ऑपरेटिव बायोप्सी में बता सकते हैं जी, उससे कंफर्म उसकी वो हो जाती है। दूसरा वो बेसिकली तो उन्होंने बेसमेंट मेम्ब्रेन को देखना है पहले, इन्वेड हो रही है तो डिस्प्लेजिया से ऊपर चला गया, और फिर उसके बाद पॉलिप के अंदर उसकी डेप्थ कितनी जा रही है। ये जो वैसे इन्होंने जो किया हुआ है, ये जो स्टडीज है, दिस इज नॉट बेस्ड ऑन प्री ऑपरेटिव, ये पोस्ट ऑप है, ये पोस्ट लीजन एक्सीजन उनके पास जो स्पेसिमेन आया उस पे बेस्ड है। इसकी बेस पर हम जो स्टेजिंग करते हैं वो रेडियोलॉजिकल करते हैं, वी डोंट स्टेज, वी कांट स्टेज इट एज अ स्पेसिमेन बी प्री ऑपरेटिवली, तो वो हाँ वो रेडियोलॉजिकल स्टेजिंग है, उसमें मैं आऊंगा। यस, वो रेडियोलॉजिकल है। सो अदर फैक्टर डेप्थ के अलावा जो इसको इन्फ्लुएंस करता है, ट्यूमर का ग्रेड, ग्रेड 1 है, 2 है, 3 है, तो ग्रेड 1 2 इज फाइन, बट ग्रेड 3 नो, गो फॉर फुल रिसेक्शन। पुअरली डिफरेंशिएटेड, जितना पुअरली डिफरेंशिएटेड होगा ट्यूमर का प्रोग्नोसिस उतना बुरा है, ये सबको पता है बात, ठीक है। सो इसमें भी दिस इज अ नेगेटिव फैक्टर, वी डोंट कंसिडर दिस दीज पेशेंट्स गुड इनफ फॉर टेमिस और टेम्स। सिग्नेट रिंग मॉर्फोलॉजी, अगेन वो पुअर प्रोग्नोसिस का फैक्टर है, एंड ग्रेड आई मेंशन यू ऑलरेडी। Lymphatic vascular invasion is an independent factor which drives how cancer will spread. So this is also, lymphovascular invasion is positive, you do not go for, you can go for other treatments, you try not to go for tumor budding, low tumor location, lower 1/3 is more prone, tumor size, all these things I'm just going to go through quickly for time's sake. And gender, male versus female, males have a poor tendency towards the prognosis. So configuration of morphology, sessile versus pedunculated, sessile lesions are more poor prognostically. Pairs classification, polyps ki, again too complicated from medical student perspective, but then again these are the differences from literature I can share with you later on. Polypoid lesion from head or stalk versus submucosa, this we have discussed earlier, जितना deep जाएगा कैंसर उतना ज़्यादा lymph node spread होगा, उतना ज़्यादा कैंसर फैल चुका है, so local treatment की जरूरत नहीं है, you go for full resection. नॉन पेडंकुलेटेड सब म्यूकोजा डेप्थ, अगेन ये वो ऊपर पॉलीपॉइड था, नीचे नॉन पेडंकुलेटेड, उसमें हम 3000 माइक्रोमीटर्स तक जा सकते हैं, इसमें 1000। एक्सोफिटिक ग्रोथ्स वर्सेस एक्सोफिटिक अल्सरेटेड ग्रोथ्स, इसमें भी फर्क है, जो अल्सरेटेड ग्रोथ्स हैं उनमें लिम्फ नोड स्प्रेड या लोकल रिकरेंस के चांसेस ज्यादा होते हैं। नाउ दिस इज हाउ वी असेस राइट नाउ फॉर टेम्स। कोई भी मरीज हमारे पास आता है लीजन के साथ, सिम्टम्स हैं उसको, मोस्टली इस तरह की सिम्टम्स पाकिस्तान में ये डिजीज बहुत कम आती है। Reason being, the patients come to you when it's quite late. Early lesions, I have done only one case in Multan so far of an adenoma in 2 years. So I haven't seen any cancer, not going into the surrounding structure so far. So this is good for discussion, but it's better to know these things. Once you go abroad, you might see more of these. So with more screening, we are seeing early cancer. So symptomatically, these patients might not feel anything. And that is why it is very difficult to convince them for a major resection. So what we do is you do a colonoscopy, you find this lesion, you do biopsy, and then you screen them with endoscopic ultrasound, endoanal ultrasound, or an MRI scan. Now, this is a very good study I was going through the other day, and basically it shows how endoscopic ultrasound and MRI have their sensitivities towards picking up these lesions. For muscularis propria invasion, sorry, the good sensitivity and specificity for ultrasound is higher. For perirectal tissue invasion, sensitivity of ultrasound was significantly higher than that of CT, and MR imaging specificities were comparable. For adjacent organ invasion and lymph node involvement, estimates for ultrasound, CT, and MR were comparable. In short, what we as surgeons need to do is when we detect these lesions, we should ideally have both investigations. Ultrasounds are not readily available. It's very operator dependent. So instead of sending to somebody that you're not confident about, get an MRI scan. An MRI scan will give you a good idea how deep this lesion is. Is it T1, T2, T3? And then within T1, if you want to further subclassify, MRIs can help to some extent, although it can overread. It has a low specificity, or endoscopic ultrasound is more ideal. So after all of this data review, we see that lesions, there are low risk T1s and there are high risk T1s. Low risk, which are well to moderately differentiated, grade 1 and 2, SM1, and less than 3 centimeter in size. And high risk lesions are which are poorly differentiated, grade 3, mucinous, signet cell, adenocarcinomas, lymphovascular invasion is positive, SM2 and SM3 depth of the tumor, and more than 3 centimeter in size. So this is what we have to establish in our patients after all the investigations, that which one of these two categories they're coming into. Now, what are the options available? One is, as I said, local excision of early disease without lymph node involvement. And which disease will be not lymph node involved? The low risk ones. Most likely plus on imaging. When you don't see lymph nodes, then it means it's lymph node free. So you can excise this. दूसरी ऑप्शन क्या है हमारे पास? हमारे पास कैंसर की ट्रीटमेंट में और भी तो तरीके हैं ना, रेडियोथेरेपी है, कीमोथेरेपी है. अब ये वो चीज़ है जो इस वक्त रिसर्च का मौजू है बाहर के मुल्कों में. कुछ रिसर्च हुई भी है, कुछ ट्रायल्स में शेयर करूंगा, कुछ अभी प्रोसेस में है. और इनका मकसद बेसिकली ये एस्टैब्लिश करना है कि अगर ये छोटा सा कैंसर जो पड़ा है, इसको हम कीमोथेरेपी दे लें, इसको हम रेडियोथेरेपी दे लें, उससे ये श्रिंक हो जाए और फिर इसको शेव कर दें, तो क्या ये काफ़ी होगा? इसके ऊपर अब वो रिसर्च कर रहे हैं. सो ये सेकंड ऑप्शन है. और तीसरी ऑप्शन एक और है जो ब्राज़ील से उठी, हबरगामा नामी एक वहाँ पर जो रिसर्चर, उसकी तरफ से रिसर्च आई कि आपने नियो एडजुवेंट की, मतलब ऑपरेशन से पहले जो थेरेपी दी जाए वो नियो एडजुवेंट है. आपने रेडिएशन दी और कंप्लीट रिस्पॉन्स आ गया. कंप्लीट रिस्पॉन्स का मतलब है ट्यूमर सारे का सारा वहाँ से खत्म हो गया. तो अब क्या आगे कुछ करने की ज़रूरत भी है कि बस इसको ऐसे देखते जाएं, ऑब्जर्व करते जाएं, ज़रूरत ही नहीं ऑपरेशन करने की? ये बहुत कॉन्ट्रोवर्शियल थॉट है, लेकिन इस पर भी बहुत काम हो रहा है. सो ये तीन तरीके हैं जिससे हम इनको देख रहे हैं और इसके ऊपर इस वक्त रिसर्च चल रही है. ये एक स्टडी है बहुत अच्छी, काफ़ी इसके अंदर इंफॉर्मेशन है. ये एसपी बैक की स्टडी है और इसके अंदर बेसिकली जो इस्टेब्लिश फैक्ट वो किया है वो ये है कि जो चीज़ अभी हमने थोड़ी देर पहले देखी कि उसने जब अपने पेशेंट्स के अंदर लोकल रिकरेंस रेट देखा 36 मंथ्स के ऊपर, तो उसमें देखा गया कि जो T1 SM1 tumors with no lymphovascular invasion, and as the size increases, you can see basically local recurrence increases. You can go both way, in x-axis and along y-axis, and you can see that the local recurrence increases as vascular invasion happens, as depth increases, as the tumor diameter increases. And this is the outcome again, showing that basically for PT1, the local recurrence rate you can see was better as compared to PT2, and PT3 was appalling. So you go for full radical resection. On the other side, again, that is showing along with the grade and lymphovascular invasion, and you can see that PT1s with low grade and no lymphovascular invasion had a higher survival. You can see that in the red line up there. And the others remaining, which were poor histology, they had poor outcomes. So how do we increase our population size? अभी तक हमने एक population को target किया, T1 cancer, SM1 depth है उसकी, उसमें good well differentiated है, उसके अंदर lymphovascular invasion नहीं है, इनको तो हमने कहा कि हम शेव कर देंगे. क्या इससे ज़्यादा आगे और लोगों को भी फ़ायदा हो सकता है? तो उसके लिए जो मोस्ट इंपॉर्टेंट चीज़, जैसे मैंने कहा कि क्या इनको न्यू एडजुवेंट दे के एक्साइज करें तो फ़ायदा होगा, और दूसरा अगर एक्साइज कर दिया है और पैथोलॉजी में वो ख़राब आ गया तो बाद में एडजुवेंट ट्रीटमेंट कोई दे दे इनको. इसके ऊपर अब रिसर्च चल रही है. एक स्टडी जो इसके ऊपर काफ़ी लैंडमार्क है वो है ट्रैक स्टडी. ट्रैक स्टडी ऑल्दो इसमें नंबर्स पेशेंट के थोड़े थे और फॉलो अप अभी बहुत ज़्यादा नहीं है, लिमिटिंग फैक्टर्स है स्टडी, जब भी आप क्रिटिक करते हैं यू गो फॉर यू असेस दीज थिंग्स, लेकिन स्टिल इन दिस स्टडी यू कैन सी दैट रेडिकल सर्जरी रेड बार से इंडिकेट हो रहा है, और शॉर्ट कोर्स रेडियोथेरेपी विद transanal endoscopic microsurgery. I consider them interchangeable. TAMIS versus TEMS, they're the same. It's just difference in the equipment. They उसमें वो blue bar से आ रहा है, and you can see overall survival. You can see radical surgery में है, लेकिन short course plus TEMS, it's not very far away. It's not very far away. It's not statistically significant. Similarly, the next one will, you can see in the slide B. These were basically randomized and non-randomized groups. So that's why there are two groups. This is the other thing is that we were discussing the morbidities, patient's quality of life. They assess the quality of life, and you can see in quality of life as well, the patients who were done with local resection had better outcomes as compared to ones who had radical resection. These two studies also give us food for thought. So CART study was done basically, and in this study what they did was they added chemoradiotherapy with TEMS. And early stage rectal cancers like T1 to T3, chemoradiotherapy enables organ preservation. This was the outcome of the study, with additional transanal endoscopic microsurgery in approximately 2/3 of the patient, with good long-term oncological outcomes and health-related quality outcomes. GRACAR 2 trial, no evidence of difference in oncological outcomes between local incision and TMEs. Local excision can be proposed in selected patients having a small T2, T3, low rectal cancers with a good clinical response after chemotherapy. So now you're seeing that we are trying to go beyond T1. They are doing and making efforts with different means. They're adding chemotherapy, they're adding radiotherapy, and they're trying to go above for higher stage cancers ताकि उसको भी minimal तरीके से हम contain करें. But these are all trials. I don't know many people who are practicing this. Now, two trials are still on the way, and these two trials are, again, a lot of colorectal surgeons must be waiting for these trials. TSAR trial, जहाँ पर वो immediate risk of lymph node disease or recurrence post stem surgery, completion surgery के बाद वो chemoradiotherapy के साथ versus देख रहे हैं. And STAR TREK trial, where radical surgery versus organ preservation plus short course chemoradiotherapy versus organ preservation plus chemoradiotherapy. So 3 groups हैं इसके अंदर. वर्कअप क्या करते हैं हम इन पेशेंट्स का? एज आई सेड, फुल हिस्ट्री एग्जामिनेशन, डिजिटल रेक्टल एग्जामिनेशन, वेरी इंपॉर्टेंट. व्हाट कैन अ डिजिटल रेक्टल एग्जामिनेशन टेल यू? If you can palpate a lesion or a polyp mobile, moving with the finger, and it's not attached to underlying structures, it means it's likely that it's not submucous into the deeper layers. So that's a good sign. So digital rectal examination is very good. It can give a lot of information. Rigid proctoscopy, why is that important? A lot of people are referred to us by gastroenterologists. They do flexible scopes. Flexible scopes cannot tell you about the right distance from the anal verge, because most of the times 8 centimeter है वो scope bend है, वो actually इससे different होती है length. So rigid scope in patients में बहुत ज़रूरी है, because जब आपने setup करना है उस कैंसर को निकालने के लिए, तो आपको पता हो आपकी इंस्ट्रूमेंट की लेंथ कितनी है, how far you need to go. And the other important factor is, after 15 centimeters anatomically the rectum is gone, then it's rectosigmoid, and then you're into the different peritoneal area. So that has its own implications, because if you're excising something their full thickness, you're going into the peritoneum, although that can be done and you can close it later on, but still you need to plan further. CA levels, personally I don't do this, I don't know the relevance right now in this case, but it should be done as in follow-up. It can be used as a marker for cancer recurrence. कोलोनोस्कोपी प्लस बायोप्सी हम करते हैं. बायोप्सी ली मोस्ट इंपॉर्टेंट इन्वेस्टिगेशन है. उसके बाद जैसे मैंने कहा, वी डू MRIs and endoscopic ultrasounds and CT tap. Again, if it is a cancer, it can spread. So you need to check all the other areas to see if there are any metastases. We will be very foolish if we keep focusing on MRI scans, remove the lesion, and then miss everything else. Yeah, so okay. So then TAMIS technique है, basically we can use these gel ports. These gel ports are used, or we can use these single incision laparoscopic surgery ports, SILS port. We can use these. The specimen extracted should be taken full thickness, so that we can have full pathology in the end, and we can decide further management plan. I'll just skip this. So follow-up in these cases, it's different for different patients. You cannot decide one follow-up for all these patients because they can have different histology variables. So post-operative clinic review in 4 to 6 weeks, flexible sigmoidoscopy in 3 months. And for malignant lesions, the NCCN guidelines are currently being followed in my setup where I was working. So I follow those, but different people have different follow-up plans. This is the case I did in Multan in my own setup. It was a guy who had a lesion and 4 years history of bleeding PR, presented with anemia, hemoglobin of 8. This was the polyp which was not amenable to resection with endoscopy. So the gastroenterologist referred to me. I did the MRI scan, did the CT scan, did the whole workup, and then we basically he has been going to other surgeons. And one of the very renowned surgeons in Multan said to him that, Sutta Sherenu Sutta Reande. And then basically he said, is that the case? And I told him, no, we should remove this. So this was the setup. I did this with a Sills port, and I used, because it was a thick pedicle, bleeding was expected, so I used a ligashore. It was around 6 centimeters of adenoma. The histology came back clear. The pedicle was negative. I did a scope in 6 months. The patient is fine. He's doing okay, alhamdulillah. So summary, select the patients with early rectal cancers very carefully. T1, SM1 plus minus 2, well to moderately differentiated, early grades, no lymphovascular invasion, size less than 3, good radiology and pathology support. Otherwise, don't do this operation. Send him to someone else or do a radical resection if you really want to do something for him. Excellent surveillance program with scope and MRI is needed after these procedures are done, because you don't know what the outcome might be for dodgy histologies. So you need to follow them very religiously. You need to be in touch with them, which is very difficult in Pakistan. Then again, if you think you're limited, don't do this. Increasing role of chemoradiotherapy with surgery in future for T1 with bad histology, and we will see what these further trials will tell us and whether we can adopt these things or not. Questions?
Follow up, sir.
Yeah.
Other parts, please. Please take the 20 minutes.
Thank you, Dr. Amir. Thank you for the discussion.
Hmm.
Making us aware of
Hmm.
minimal invasive procedures. We'll be having a question answer session at the end. So